you so much, and apologies for the laptop. As you could tell yesterday, I forgot my glasses behind there at home, so I can't actually see most of what's in front of me. So I'm bringing my laptop up in front of me so I can actually see what I'm talking about. Not that I really know what I'm talking about most of the time, but anyway. So I gave this talk in much more detail last year, so I was trying to think about something that would be vaguely interesting to you this year. And I'm going to try and whip through this, just trying to make my slides now work on my laptop. Sorry about this. It's nothing like your laptop acting up on the screen.
I did offer him mine, but
Yours an Apple or something revolting. Anyway, so these are my disclosures. Right, now to try and remember which button to push. So these are my various epiphanies. I was trying to think of something interesting to think about. As I said, trying to remember which button to push is going to be the biggest thing. So the first one is we're not going to have long-acting injectables soon. And I think this is a complicated mix of, and maybe for as long as a decade at scale. I think there might be cases around this. And the reason for this is actually probably around, it's partly because the drug companies aren't going to work together in the way that we need them to. It's also because there's not the kind of single-minded focus on the dolutegravir introduction. Until we get large numbers of donors, probably or at least one major donor, and the drug companies start cooperating on working out on the access programs and things, we're not going to see these things at scale, in the kind of scale that we need. And this article, which we published in August, sort of delineated some of the steps that are going to be required to actually get there. And this is heartbreaking because there are so many exciting things that are coming along the way, and there's such huge patient expectations, I think, on terms and advocacy expectations around this. But unless we start paying close attention to the development pipeline of whatever combination products there are in the injectable space, I'm going to talk about the oral space in just a moment, I don't think we're going to have treatment at scale anytime soon. We're going to be stuck with TLD for the next decade. So my next as I said, trying to coordinate this is proving a challenge. My next epiphany is around, there's this concept that this is going to be easy to do. The injectables are really, really hard for treatment. I think PrEP's going to be harder, but the practical thing that one of the things when I went to the Glasgow conference was going to listen to sort of people with experience of using cabotegravir or rilpivirine. There are almost no sites there which had more than 100 patients on treatment. And that scares me because, and they talked consistently about how hard it was to get beyond 100 patients. There was one site that had about 200 patients, which I think was possibly the largest site in the world. Now, 100 patients is a minor clinic, is possibly the smallest clinic in South Africa. So when people tell me it's hard to get beyond 100, you're telling me that that's an operational challenge of note. And I think we need to start thinking very quickly about if we are going to scale injectables for treatment. Next kind of sites that he's been looking at in the case studies are possibly one of the largest, operational sites in the world. And we're going to have to learn very quickly to start scaling up our injection sites for treatment. I think we're starting to learn how to do it for PrEP. But the kind of operational thing, this idea of saturation complexity, they also described something which I have noticed in our own sites, a lot of physician resistance. It's just the whole process of getting somebody onto injectables was very, very hard. And just the mundane issues of patient scheduling was difficult. And I know from my own site that it is a bit of a gedunte to get people along into that. So my next epiphany is that I actually think long-acting weekly treatments are going to be the next blockbuster, and it might actually be the next blockbuster in our region as well. It's certainly going to be it in rich countries. And they actually might be pretty transformative. And my initial instinct around this was like a bit of a distraction and that they weren't actually particularly interesting. But I do think we need to think about this. The PEPFAR program spent billions of dollars trying to get us to multi-month dispensing. And we need to start thinking about, rather than giving 28 tablets for a month or 30 tablets for a month, we could give people 28 tablets for 6 months. All those dramas about creating 6-monthly systems of bring patients back, you could actually get away with minimal packaging for 6 more months. And there's no need to create that complicated injectable system. The current dispensing system actually works for it. So we need to start thinking about these weekly tablets as being something that's going to be a step in the right direction. The future might be injectable, but the interim, for the next few years, certainly I think that particularly as some of these dual-acting weekly tablets are actually going to be very, very cheap. So, sorry, just trying to get this to coordinate. My next epiphany, I think this might be the last one you'll be delighted to hear, is that injectable PrEP is going to change things. And I think you heard that from Linda Gale. I'm not going to labor this thing, but there are lots and lots of exciting things on their way, which I'm going to touch on in just a moment as well. One of the things you do need to be reminded about, and I'm not going to labor this because I labored it last year, is that patient acceptability for injectables is very, very high. So if there are questions here about do patients like them, yeah, there's tons of data that patients love them. They love them far more than the healthcare workers do. So just get past it, make your peace with it. If you don't think that's true, it's true. It's true for men, it's true for women, it's true for everybody. So I put this up just to remind people for treatment that TLD has set up a very high bar. It's an incredible step forward for public health, and it's been shown over the last few years to be, it's cheaper, it's better, it's really been incredible for how much it's settled. Major reason I showed you the slide is I spent 5 days putting together this AI-generated graphic because I think you really do need to see it. So what are we talking practically? There are only a few formulations actually registered by the FDA. This is the same slide I used last year, which is cabotegravir with rilpivirine for treatment. Cabotegravir is registered for prevention. Lenacapavir, which is registered for treatment in highly experienced patients. The problem with these three formulations, they're all made by different companies, all with very competing commercial interests, which makes life very, very difficult with us, all with different global mandates, which also makes it very difficult to do treatment studies because you have to negotiate with 2 different countries. Now, I'm going to talk about one of the companies which is just kind of checked out of any sort of engagement. There are lots of other agents, one of which is latravir, which is about to hit us all, and there's a whole lot of others I'll chat about in just a moment. So the first agent is, and I'm going to just summarize, you can look at my slide deck, I'd go into much more detail on each agent last year, and I'm just going to touch on a few updates since then, is cabotegravir, which I think all of you have heard about, which is the new generation integrase inhibitor with a high resistance barrier. We give it 2 monthly. There's a whole lot of studies looking at pushing it out to 3, 4, 6, maybe even longer monthly in various studies. It's given intramuscularly. It's pretty complex to administer. This is not something you roll out to primary healthcare nurses who've got training giving intramuscular contraception. This is not the same thing. You really do have to give it in a way that is pretty specialized. It's got a long tail, which makes it the reason you can give it as a long-acting, but that long tail, which varies quite a lot, can reach out to here, is a double-edged sword because it also allows, if you're giving it as PrEP, breakthrough infection, which gives you lots of time to get resistance, and also if you're giving it with a second agent, if you don't give that second agent with exactly the same half-life, you're going to get resistance if that person falls off therapy. The safety profile is excellent. By and large, just some local reaction. Cape Town's given it once or twice intravenously, and that can be very, very scary, as Catherine's in the audience will tell you. I certainly am not going to be giving it anytime soon. But as a drug, this thing performs very well for what it needs to do. The drug is highly effective as PrEP, as Linda Gale has shown you. It's effective in treatment as a switch therapy with rilpivirine. There's some concerns about breakthrough, and I'm hoping Anna will touch on some of this. It's been used off-label for patients who are viremic, and this is actually where it's most exciting, is patients who are battling with adherence to oral therapies. It's shown to be actually really effective there. It's also been used off-label increasingly with lenacapavir, and one of the frustrations we have is not being able to do the clinical trials with it to prove that we can do it well. The big controversies, of course, have been around access. There was delayed access to generics. Again, I covered this last year. It's still completely unavailable. It's going to be 2 or 3 years before we have it available in generic form. It's extremely high cost, and actually, you can't actually buy it from the company. We can't get access to it, and it's been very frustrating being able to do demonstration projects because we have to get donations from the company. So what about rilpivirine? Now, rilpivirine is another source of much frustration for people like us who are trying to get access to work with these drugs. And I know that there have been several petitions around. This is another NNRTI with a fairly high resistance barrier, higher than, say, for efavirenz. It's given as a separate injection to cabotegravir for treatment. So you must remember, you're giving now 2 separate injections when the patient comes in. As I said, it's got this it's the barrier to resistance. It's also dosed 2 monthly. I was initially told that it couldn't go for longer, but I hear that there are actual now research interventions to try and see if we can push it out longer to sort of pair with cabotegravir. Also given intramuscularly, it needs a cold chain. It's the more painful of the 2 injections. Same side effects, some local reactions. You need to have a genotype in high-income countries. There's no way that's ever going to be a reality here. The most frustrating thing here, though, is there's no access plan. The companies just stepped away. In Munich last year, it said, we're not going to enforce the patents, and we haven't heard anything since. So there's no message to the generic companies. There's no message to WHO. It's just being complete disengagement over this issue. And it's really frustrating, even for the companies like ViiV who have to actually deal with trying to promote these combinations. So the new kid on the block, the one everyone's excited about, is obviously lenacapavir. It's a completely new class, capsid inhibitors. You can give it orally, you can give it daily, you can give it weekly, you can give it subcutaneously, you can give it intramuscularly. I think we're just waiting for the sublingual and intraanal preparations to come along. And the intramuscular one, which I'll talk about in just a moment, is possibly the most exciting one now. But even the 6-monthly subcutaneous version is the one that I think has really electrified us. It's very well tolerated, although the pain is not to be underestimated. Even though the company minimized it, it was very quick to look at intramuscular administration, and that has also been significant. So there is that. It's not overwhelming, but it is there. It has a fairly high resistance barrier, but you can get over that. And as I said, it's been approved for pre-treated ARV patients at the moment. It does need an oral lead-in, and that does create all sorts of complicated issues around things like for the practical use of it. The API is complex to make, and there are research efforts to make it easier, but it's actually not. The drug itself isn't that difficult to make, so it should be pretty cheap to scale up, and Linda Gale touched on some of this. It's potentially transformative, and if we got to the intramuscular form, which looks like it could be given annually, there was earlier data published earlier this year, maybe even 2 yearly, you can imagine how that could transform our systems. But the politics have been so frustrating, with Gilead not being transparent about how the program is going to go forward. And for both ViiV and Gilead, this has actually been really frustrating because both companies have actually been really good about access. ViiV around dolutegravir, Gilead around all their drugs in the past, and both of them have just been really not transparent about how we're going to get access to these drugs. So what about my favorite drug, which is the soya sauce extract, which is islatravir. And this drug, which is a completely new class, sort of linked to another class, is a nucleoside reverse transcriptase translocation inhibitor, which you can also give daily, weekly, monthly. It was initially a big PrEP drug, which has now been resurrected again, but it's mainly made its way into treatment, where it's got a high resistance barrier, very well tolerated, low dose. All the safety and resistance data is very encouraging. And the current plan at the moment is to take it forward as an oral weekly combo with lenacapavir. And this is where this is probably going to be the first dual therapy weekly tablet registered. And if the patent was handed over to generics, it looks like it would be very, very cheap to make. The phase 2 data is very promising so far, and I think it's either going to be registered later this year or next year. However, there are no access discussions at the moment, and there's minimal pregnancy data, although that's steadily getting better and better. So again, something to be watching with a creative eye, I think, going forward. There are other dual therapies on their way. There's the combination. Gilead's got a lenacapavir with Insti. Merck's got another NNRTI with islatravir. I understand ViiV's got another combination. So all the companies are working on this. So the fact they're all working on it does suggest that everyone thinks this is a big deal. I mean, obviously, we've never done weekly tablets, so adherence, we're going to have to get our heads around that. The psychiatrists and many other people have worked with weekly before, so they do know how to do this. As always, sorry, I jumped through that. Pregnancy is always an issue. You know, people might say, why did we wait for the injectables? As I said, I think that's a long way away, so I think it's worth looking at these weekly ones. Should we just work on this as a side project? I think it's certainly worth doing. There's a whole of other areas that we do need to start paying attention to. Almost last few slides. Firstly is the antibodies. With antibodies, they're the believers and the non-believers, I feel, but people are working on this. Gilead certainly is working aggressively because they compare it with lenacapavir, and the initial study results are pretty good. There's a lot of optimism in this field, but not many results that I think are going to go forward to phase 3 and phase 4, or to commercialization. There's a long-acting TAF in the mix. There's a variant on a new Merck islatravir product, which is looking very exciting. And as usual, there's a whole lot of other stuff that could be working in the background that we don't have access to that data yet. Suddenly gets sprung on you. Interestingly, there's a subcut injectable TLD that's been developed at the University of Washington that we're involved with at the moment. The problem is, and Linda Gale touched on this, the elephant in the room is this. And I don't know how to actually even talk about all these new innovations and when there's complete collapse of many of the treatment programs in our countries. And we're going to have to work out what we do just to make sure that TLD is available to our patients going forward. And with the collapse in many countries, and then just the hammering of even the countries like mine of the treatment programs, how are we going to protect those in an era where it suddenly feels like I'm talking in the fantasy land about new innovations like this. But we are going to have to keep these things at the front and center of our thinking as we go forward, because we can't just be thinking about today. We've got to be thinking about how these things are going to play out as we redesign our programs around a completely different world of antiretroviral access. And I think this slide that was published earlier this year shows, particularly for the PrEP programs, how dependent globally the PrEP programs were actually on PrEP. And certainly in South Africa, our PrEP program is non-existent, despite our minister telling us it's all fine. It's just completely collapsed. And by talking to everyone around here, it's the same for every single African country. And we do need to start thinking about what are we going to do different. So my last slide is this, it's having no access to promising agents for the necessary studies is really frustrating. And we can't change guidelines, we can't do demonstration projects until we have those drugs in front of us to start playing with them in the real world, to start taking them forward. And even if all the drug companies gave them to us tomorrow for free, we would still need to be doing all of these studies. We'd need the donors to be funding the studies, to taking them forward, to doing the switch studies, all the various studies that we know we needed to do to get dolutegravir into the system, to take it forward, particularly for treatment, and we need to be doing it at scale. And then we're going to have to work out how to scale things up, particularly for the injectables. We're going to have to build those systems. Even if we get these weekly tablets, we have to work out how to do that. What are the adherence support systems that are going to be required for that? So my final message is there's tons of work ahead, particularly in the world where suddenly our biggest donors suddenly had the rug pulled out from underneath us, has pulled the rug from underneath us. So it's an exciting time, but it's a very complicated time. And it's going to be a tragic time if we don't take these new innovations and technologies into the rightful place simply because we don't have the funding or the drive or the creativity that we require at this pivotal moment. Thanks, everybody.